Hello, my name is Jennifer Stransko, and I am the Physician Engagement Associate for MAVEN Project. Thank you all for joining us today and our friends at Mariposa Community Health Center for hosting today's session, How to Assess Cardiac Concerns in Children and Adolescents in Primary Care Clinics with Dr. Claude Rogé. After Dr. Claude Rogé completed his pediatric cardiology training at the University of California, San Francisco, he was hired at Kaiser Permanente, Northern California. He remained on the clinical faculty at UCSF, eventually becoming a clinical professor of pediatrics. After retiring from Kaiser, he became the medical director for School Health Clinics of Santa Clara County, SHC, and FQHC, serving the underserved population in Santa Clara County, California. In addition to his administrative role, Dr. Rogé still sees children presenting with the most common cardiac conditions in his clinics and reads EKGs. He continues to work as a pediatric cardiologist at UCSF several days a month. And with that, Dr. Rogé.
Okay, good morning, everyone. Hope you are doing fine. And so let's start here. I have some disclosure here. I have no financial relationship to disclose here. Let me see. Jennifer told you already about the CME issue. Okay, so, you are primary care providers, most of you, and there will be many situations in which you will have to rule out heart disease in children. And that would be in the context of doing a sports physical, when you hear a heart murmur, or when the patient has hypertension or symptoms. In order to rule out heart disease, as you know, it is necessary to obtain a careful family history, looking for genetically transmitted disease. It's important to take a careful history of the events surrounding the apparition of symptoms, do a complete cardiac physical evaluation, and order the appropriate test, and decide when it is appropriate to refer to pediatric cardiology for further evaluation. But if you have some experience with pediatrics, most of the time, even if there are symptoms or murmurs, you will conclude that there is really no heart disease, and all you have to do is actually reassure the patient and the parents. And that can be a challenge. So we are going to talk about all this. Okay, so this is from essentially what we're going to talk about. The introduction is done, so we can go to sports physical. Okay. The few circumstances when you are in a position of having to suspect and exclude or detect heart disease is when you are doing a sports physical, and when, as a primary care provider, you detect a heart murmur, hypertension, or the patient is presenting with symptoms. So let's start with the sports physicals. Now, pre-participation physicals are mandated in nearly every organized athletic program and are performed with the intent of identifying any condition that may preclude an athlete from safely participating in athletic events. So what I'm going to show you is a pre-participation physical evaluation form that was developed by all the organizations that are involved in that type of medical care and screening. As you can see the list here. So the patients coming to your clinic may already come with their own form from the school. That's often the case. Or in your own clinic, you may have your own form. But usually the forms that most people use are from this conglomerate of organizations here. So this is, for instance, the form that's published by the American Academy of Pediatrics. And there are two essentially parts to it. One here is a history that's completed by the patient or the family. And then on the right, the physical examination form that you complete, you as a clinician. So in the history form that the patient or the parents complete, you can see there are lots of questions that are actually trying to detect if there is any red flag here for something that could be cardiac. So a big one, any symptoms occurring during or after exercise is always a red flag. So you always have to figure that out. What's the timing exactly? So you see there are a few questions here, number 4, 5, 6, exercise, 9, exercise. So any symptoms that occur during or after exercise is a red flag, and you will need to evaluate that a little more carefully. And then he goes over a lot the family history, okay? So the family history here, and we will talk about it more when we review those conditions, basically, you want to make sure that in that family there is no one who died suddenly and unexpectedly before 35 years of age. That would be a big red flag as well. And then, of course, you have all those genetic conditions. Now, if you just ask, did your family has any genetic condition, they don't know what you are talking about. But if you go over that list of conditions there, and if a relative has one of them, that may ring a bell for them and say, oh, yeah, he had a long QT syndrome, my grandfather, or something like that. And then, of course, you know, if someone in the family has a pacemaker or a defibrillator put before the age of 35, that also will be something of concern. And then there are, of course, other questions looking at all the other organs that, of course, you're not going to neglect. But there is a sizable portion about the cardiac history. In the physical examination form that you complete, you can see also there is a focus on condition that may raise the question of a heart problem. So the first one here mentioned is a MAVEN stigmata. So kyphoscoliosis, high arch palate, pectus excavatum, arachnodactyly, hyperlaxity, you know, the thumb sign where you put your thumb like this, and MAVEN syndrome, it goes past the edge of your hand, mitral valve prolapse, all those things. So it's important to see if there is anything that would suggest MAVEN syndrome. And of course, murmurs, and the key here, and we will go over it again and again, when you hear a murmur, it's very important to listen in different positions, because, you know, most innocent heart murmur are going to be louder in the supine position, and they get softer when the patient goes up in the standing or sitting position. And it is the other way around with hypertrophic cardiomyopathy. The murmur gets actually louder in the supine position. So very important to do that, and it can be very helpful to detect hypertrophic cardiomyopathy. So the focus of the PCP is to rule out the rare cardiac conditions that can cause sudden cardiac death during exercise. So just to put it in perspective, sudden cardiac death in adolescents is a fairly rare event. You can see if you compare it with vehicle accidents, drowning, firearms, even lightning is twice as more frequent than sudden cardiac death. So it is a rare condition. And as you can see in terms of the cause of death in children and adolescents, heart disease really is not very frequent. There are lots of other much more common cause of sudden death. So it's not going to happen often, but you need to see if you can detect those conditions and act appropriately. So these are the most common cause of sudden death in competitive athletes. And by the way, this study was done on athletes younger than 35 years of age. So some of the conditions, like from coronary heart disease, are going to be, of course, very rare in children. Coronary artery anomalies, however, is going to be the second cause of death in children. So it's something to keep in mind. And rupture aorta, we talked about it also. That's in the context of Marfan syndrome, usually most of the time. And that's the third most common cause. So what we are going to talk about as those three primary causes: hypertrophic cardiomyopathy, coronary artery anomalies, and rupture aorta. So is there a way for you to suspect this condition and prevent sudden death? Okay. So very brief review on hypertrophic cardiomyopathy. On the picture on the left show you the normal myocyte. You can see they are very well arranged, the thin and thin myofilaments. And in hypertrophic cardiomyopathy, it's very chaotic. There is myocyte disarray and interstitial fibrosis, so it looks very different. Now, of course, in a primary care provider, you are not going to see that. But let's go over, as we mentioned before, is autosomal dominant. Now, the problem with that is that the penetration varies tremendously. So you may have people who die suddenly in their 20s because they have hypertrophic cardiomyopathy, and you may have other people who are totally asymptomatic, goes through life, and then in their 60 or so, they need to have a surgery for something else, a fracture or something. And the anesthesiologists say, well, let's get an EKG before anesthesia. And there, boom, they see, LVH, and they do an echocardiogram, and they detect hypertrophic cardiomyopathy. So that's a problem. But of course, if someone tells you, yeah, my grandfather died suddenly, and we don't know why when he was 30, that would be a big red flag. Now, this is a fairly frequent condition, okay? Is more frequent than Down syndrome. So if in your practice, you have a couple of patients with Down syndrome, you should have detected as many or slightly more patients with hypertrophic cardiomyopathy. Now, how do you detect that? Well, symptoms, okay? As we mentioned before, any symptoms with exercise, chest pain, palpitation, or fainting with exercise is a red flag, and you need to rule out hypertrophic cardiomyopathy. So you would do that by taking a family history and then listening carefully. And as I mentioned before, you may hear a murmur, a systolic ejection murmur, that's actually louder in the sitting and standing position than it is in the supine position. This is the different from the normal heart murmur. That's the opposite of the normal heart murmur. And in those cases, you are going to get an EKG. You can probably do that in your clinic. And there you will see there is an LDH, deep Q waves, abnormal QRS complex, SCT segment abnormality. So if you have any of those things when you do a sports physical, the patient needs to be evaluated further, okay? You need to refer him. The next step is going to be an echocardiogram, and that will confirm the diagnosis. The next one are coronary artery abnormalities in children. Okay, it's much less frequent than hypertrophic cardiomyopathy. On top here, you can see the normal arrangement. The left coronary artery comes from the left coronary sinus, then it is split into the left anterior descending and the circumflex, and the right coronary artery comes from the right coronary sinus. And you see there are a variety of different abnormal origin, abnormal course, like going between the arteries here. There are multiple reasons for that. In older patients, there will be acquired causes. So if you do a sports physical in a 30-year-old man who is going to play competitive sports, you may want to consider that. And you can go over all those things. One thing that apparently, there are a number of drugs that can cause coronary artery vasospasm. So you may want to review that carefully as well if there is any history of drug, and if necessary, do some drug testing in that group of patients. So how do you suspect the coronary abnormality? So family history of coronary heart disease, that would be for, the atherosclerotic type, which would be rare in children, but more and more common if you take care of young adults. Again, symptoms of chest pain and syncope with exercise, again, that's a red flag. And then in that case, you would get an EKG, an abnormal EKG. And depending on the context here, you may get some blood test. If it is a recent patient, say, yeah, I just started having chest pain yesterday, you may want to get troponin. And then if you ask about drug, and the patient is taking any of those drugs there, amphetamine, cocaine, and all that, drug screening may not be a bad idea. So these are some of the references here. Now, rupture aorta is a more rare condition, and that's going to happen in the context most of the time of Marfan syndrome. And again, as we mentioned before, you can see it's much less frequent than hypertrophic cardiomyopathy. But it is actually for you a little easier to detect because they usually have typical physical findings: kyphoscoliosis, high arch palate, pectus excavatum, arachnodactyly, hyperlaxity, myopia. If you listen carefully, they may have mitral valve prolapse. Now, there are other causes of aortic root dilatation, of course, but like the most common one is bicuspid aortic valve. But, because that's 1 to 2% of the population has that. But usually the aortic root dilatation is not bad enough in children to cause a risk of sudden death from aortic rupture. But as the patients get older, that become a potential thing. Now, in that case, you will hear a systolic ejection click at the base, at usually the apex. And then with bicuspid aortic valve, if it has progressed for a while, you may have evidence of aortic stenosis or insufficiency. But again, this is going to not be a cause of sudden death in children, most likely. But if you hear that systolic ejection click, a murmur, probably that deserves further evaluation. Now, atherosclerosis is rare in children, but you are going to still ask about the family history of early cardiac death, hyperlipidemia. If there is anything suspicious, you can get lipid panel and look into that more. All right. So unless we have question, we can just make a conclusion for that. If the patient has symptoms with exercise and or suspicious clinical findings, like for instance, a heart murmur louder in the standing position or Marfan's phenotype, further cardiac evaluation is recommended before giving the green light for sports participation. So before I go to the next topic, any questions about this? Okay.
We do have one question in the Q&A. What is the youngest age you have seen atherosclerosis?
Atherosclerosis. Yeah. Well,
And she added significant enough to cause symptoms.
yeah. There are some very rare genetic symptoms that can cause that in young kids, but that's going to be extremely, 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 extremely rare. So again, if you have a family history of early heart disease, it's not a bad idea to get a lipid panel in the child as well. And then based on your results, then, personally, I was when I was practicing on a regular basis, if it was really abnormal, even in a young kid, I would refer them to a pediatric lipid specialist, because these are extremely rare conditions, and exactly to know when do you start treating, what medication you use, unless you do it all the time. And again, it's so rare in kids that it doesn't happen very often. So I could not be a specialist of that. So I would always refer to someone at UCSF who was specializing in lipid disease, in children. So
We do have one more question. Do you recommend screening EKG for asymptomatic competitive athletes?
It's a good question, and it's very controversial. There was only one study that was from Italy showing that it was useful. Most other studies have shown that it really doesn't help and it's confusing. And we go over that. The problem is that EKG is a very good test, but is also not a very good test in the sense there are lots of false positives. So I can guarantee you, if you get EKG on every sports physical, you are going to have to refer lots of patients to the cardiology, which can be an inconvenience for the patient and the family. And then most of the time, it would turn out to be a false positive. So all the other studies, except for the Italian, did not show a really good value for that. So I would not recommend it routinely. I would definitely recommend if you have a red flag. Red flags, again, any symptoms with exercise, murmurs that louder in the sitting and standing position, family history of heart disease, yes, then it's a good idea to get an EKG, but not every patient going to play competitive sports. I do not recommend it. Okay, good questions. All right, so let's go to the next thing, very frequent that you are going to be faced is someone with a heart murmur, okay? So this is a case here, is a healthy 5-year-old boy, and you have been following him since his birth. And for the first time, you hear a grade 2/6 musical systolic ejection murmur at the left sternal border in the supine position. I know there is you probably cannot hear it. I have even a hard time hearing it myself there. But so the question is, what do you do next? Okay, so you review the family history, and there is no history of early cardiac disease, so that's good. You review the past medical history carefully, no cardiac symptoms, normal growth and development. You do a careful physical examination. You already did a quick one and you heard a murmur. Now you are going to check the capillary refill. Of course, you will have done an auto-saturation probably, but if it was not done, you repeat it again, you do it again, and it is normal. Then, very important, you took the pulse in all extremities. So usually you start by taking pulse in both arms, and if they are equal, then you can choose any arm and one leg at the same time, and you make sure there is no radiofemoral delay. Then, of course, you take the blood pressure. Ideally, you take it also in one arm and one leg. So you see that that's a normal pattern where it is the systolic is a little higher in the legs than in the arm, and the diastolic a little lower. That's kind of a normal pattern. And then you repeat carefully the auscultation. Normal S1, you hear a splitting of S2 at the base, and only when the child is inspiring, is taking a deep breath in. And you don't hear any extra sound, no click, S3, S4, and then you listen to the murmur again. And it is a musical twanging sound like that made by twanging a piece of tense string, and is louder in the supine position of the left sternal border and harder to hear in sitting and standing position. The murmur is not transmitted to the neck, axilla, and back. Diastole is clear. Lung auscultation is normal, and there is no organomegaly. So in your clinic, you also check the hemoglobin, and it is normal. So what do you do next? Okay, and let me see. Here, well, you said probably you would say, oh, I hear a murmur. Could I be missing a heart defect? Now, I listed here the prevalence of a congenital heart defect detected in Atlanta recently. And this is in order of frequency. And in green are the conditions that you, as a primary care provider, are likely to detect before it is screened, in utero shortly after birth. Okay. The other conditions, like tetralogy of Fallot, atrioventricular septal defect, transposition hypoplastic, single ventricle, all these probably would have been detected. But the one in green is the one that you may be the one suspecting it first. So the VSD, as you know, in utero, the pressure on the right side of the heart is as high as on the left side of the heart. So if you have a VSD, especially if it is a muscular VSD, and even if the child, the fetus has a fetal echocardiogram or ultrasound, that's going to be missed in utero because there will be no shunting across the VSD. You will not see a jet going from either the left ventricle to the right ventricle or the right ventricle to the left ventricle because the pressures are equal. And the same applies, that reasoning applies to the neonatal period. It takes a while for the pulmonary pressure to drop. A very healthy kid, maybe in 24 hours, is already lower and you may hear the murmur. But, some kids, they go home early in the same day as birth, if everything goes well, or the next day, and the murmur may not be there. So you may be the first one to hear that, and you can see that that's the most frequent. And that would be, though, quite different from the murmur in that case. You would be a pretty harsh murmur, is pansystolic, is, going from S1 to S2, and it doesn't change with position. So that's a very different type of murmur. You will not miss that. So the second condition is an ASD. Now, an ASD, again, may not be detected in utero or at birth because, we all have a PFO, which means we have some shunting across the atrium in utero. In utero, it goes from the right atrium to the left atrium. But it is hard to detect an ASD with a fetal ultrasound. And for sure, it's very rare as a newborn that you are going to suspect that because, again, there is that same idea of the pulmonary pressure. It's really preventing a big flow across the atrial septal defect, and so you won't hear the murmur. By the way, the murmur is usually through the pulmonary valve, the increased volume of flow going through there, making sound. So usually you hear that at the base, of the, and not at the apex, and usually there is a widely split S2 with ASD. And PS, now severe PS is going to be detected, in the nursery, but very mild PS, again, maybe missed because of the pulmonary hypertension again and the very fast heart rate in the newborn. And then you will be the first one to hear it. Again, murmur at the base, systolic ejection click. Now, coarctation of the aorta, again, that's very important for you to keep that in mind. It's not a very frequent cardiac condition, but it's very important that you are the one detecting that, and you detect by taking the pulse at the same time in the arm and the legs. And if there is a suspicion that it is weaker in the legs, you take the blood pressure. PDA, okay, but the problem with PDA, every newborn has a PDA. It may take a few days to close in a full-term baby. And so, it may not be suspected in utero, of course, in utero, everyone has it, or shortly after birth. And so, if it stays open, you will be the first one listening. And that, of course, is going to be usually a continuous murmur at the base, in the axilla, in the back. So that would be pretty different from what you just heard there. Aortic stenosis, again, severe is going to be detected before they go home, but mild aortic stenosis may just not be detected at first. And that would be a systolic ejection click at the apex and a systolic ejection murmur at the base going into the neck. So you go over all that, you say, okay, I don't hear any of those suspicious findings. The murmur I hear doesn't sound like any of those conditions. So, this is a question. What do you do next? You have gone through all this, your physical, in your mind, what all the options are. And these are the three options. And option number one is reassure the child and parents. One has a normal heart sound. We often hear it in healthy children. We call it innocent heart murmur. Or option number two, you order an ECG. Or option number three, you refer to pediatric cardiology for further evaluation. So I'm curious, if you are in front of your computer, you may want to put that in the chat. Do you go for number one, number two, or number three? You can also unmute yourself.
Somebody replied with the number one.
I barely hear you. Can you speak louder, please?
Oh, somebody replied with the number one.
Very good. Okay. Any other one?
Number three.
Number three. Okay. I guess I discourage people doing EKG after answering the first question for sports physical. You know what? Okay, I'm going to tell you, there is not one good answer here, okay? It all depends on a number of factors, and mainly it depends a lot on your comfort level. And let's clarify also, some people are better than others about hearing heart sounds and murmurs, okay? I worked with some excellent pediatricians who really could not get that together. It was hard for them to figure it out. So if you had the chance to work, with a cardiologist or someone who is experienced with that, and you feel comfortable, and you have seen a few cases, and number one is definitely a very good option. Order the ECG. Again, we went over sports physical when you want to order an ECG. So here you hear the murmur. You are going to go over the family history carefully, okay? Definitely, if you have a early cardiac event in the family, or if you are not totally sure about the murmur, it's not a bad idea. But the problem again with EKG is that you are going to get loss of false positive. Refer to pediatric cardiology. It depends again on your situation. There are some health clinics in very remote area. It is really difficult for the family to bring the child to the pediatric cardiology. And, most of the time it's not necessary. So you have to weigh all those things and decide what's the best option in your situation, in your particular situation. Now, I'm not going to go over this, but for your reference, if you say, well, he talked about only one type of an innocent heart murmur, that's right. There are different types. We talk about the number one. There are that's Still's murmur that we discussed. but there are also outflow systolic murmur, and there are details there that you can review, so you will have it as a reference. And then there is also systemic flow murmurs and venous hum. So I'm not going to go over that, but if you are curious, you have that reference here, so you can go over it. So ideally, the primary care provider is comfortable after a thorough clinical evaluation in making the diagnosis of innocent heart murmur. But again, I'm not saying that everyone should do that. It depends on your comfort zone, okay? And in that case, you are going to be reassuring the parents. In that case, usually the electrocardiogram is not indicated. False positive may increase the anxiety of the family and will require referral to pediatric cardiology. But again, the level of comfort of the primary care provider depends on the training and the hearing capacity. Now, I would say reassuring the parents can be a challenge. And that's because this is what goes through the mind of a mother when you tell her that the child has a heart murmur, okay? They start really worried about. Half of them say, oh, he's going to need medication. 40%, more than 40% is going to be restricted from sport. A third say, oh, he's also going to have cardiac surgery, like my second cousin who had heart surgery 3 years ago. Oh, and my other kids are going to be going to have a heart problem too. Oh, it's because I did something wrong during pregnancy. Oh, he's going to die early. So why is there so much anxiety? Well, for one thing, okay, it doesn't want to move now. Uh-oh. I cannot move forward my slide here. What's going on? Okay, there it is. The reason there is so much anxiety, one reason is that, of course, heart disease is the #1 cause of death, at least in the US here. So most people have a parent or a friend who has died of heart disease. So that's one reason. The other reason is that news media always report the rare case of sudden death in young athletes. This was a report in the Mercury News. And, it's very rare, but people are going to be aware of it. And why so much anxiety? Because, of course, the heart is the most important organ in the body. Now, you will expect me to say that as a cardiologist, but let me tell you, it's not only cardiologists believing that. If you go back to ancient Egypt, after you died, you had a process here where a god takes you to, it's called the Hall of Mat. And what they do, they take your heart, they put it here on a scale, and they put a feather on the other side. So if your heart is as light of a feather, then you are taken to the afterlife, and you have made it. You're okay. If it is heavier than a feather, then there is another type of god here that's a monster, and he eats up your heart, and that's the end of you. So, the heart, very important in ancient Egypt, as you can see. As you know, in the Aztec culture and other Mesoamerican culture, the heart was also very important because it belongs not only to the individual, but to the sun gods. And of course, the sun gods sacrifice themselves and fight against darkness. And that's the only way man can survive. So in return, of course, man must sacrifice to the sun gods. And the best offering is a beating heart. Now I put a god here. It's not actually I like the colors and all that, but it's not a sun god, but it's another god from the Aztec culture. I will not pronounce the name either. It's too complicated. So this is not done anymore, but we are reminded that the heart is really a special organ. If you go from Quebec all the way to the tip of South America in Chile here, you have Sacred Heart University, and all this is Sagrado Corazon. Okay, so all these things all over the Americas remind you that the heart is a really special organ. Okay, and it is also true in multiple cultures. If you see that in the little space within the heart is as great as a vast universe in India. And in Western Europe, it is only with the heart that one can see rightly. What is essential is invisible to the eye. So it's very important, okay? So that's why you will have to spend some time reassuring the parents, and it may not be as easy as it seems to you. Okay, we need to move on to the second case now. Is an 8-year-old boy who is scheduled for a routine well-child physical with you. And Arthur has been followed by a colleague of yours, so you review the chart and you see that he's overweight and he has mild hypertension, and he had normal laboratory result, normal lipid panel and renal function. And actually, Arthur was seen 1 year earlier by a pediatric nephrologist who diagnosed mild primary hypertension related to overweight. So what do you want to document on this physical exam? Anyone wants to give an answer here? In the chat or... Okay. Well, let's go to the next stage then, if no one wants to take a chance. You measure the blood pressure in 4 extremities, okay?
Oh, someone wrote, make sure no abnormal abdominal sounds.
Abdominal what sound?
Yes.
Yeah, that's and I could ask why that person say that, but I will guess it to save time, because you have rare cases of renal artery stenosis that can cause hypertension, and so it's important to listen to the abdomen. So that's a good point. But the most common cause, and at least as far as the pediatric cardiologist is concerned, is going to be coarctation of the aorta. So I am going over a few slides here, but basically what you want to do, from my point of view, is I'm not saying it's wrong to listen to the abdomen. I think it's a very good idea, the abdomen and the back, very good idea, and I recommend that. But also what I recommend is you take the blood pressure in 4 extremities, or at least, you take it in both arms, because there are abnormal connection of the subclavian artery sometimes, and you will have very strong pulse and hypertension on the right arm, and very weak pulse and normal blood pressure in the left arm. So then you would take the blood pressure in the right arm and in the leg, and you would get a comparison. So normally, as we said before, the systolic blood pressure is a little higher in the legs than in the arms, and the diastolic blood pressure is a little lower in the legs than it is in the arms. And here you can see that in that patient, he has definitely hypertension in the right arm, borderline in the left arm, and then a normal blood pressure in the legs. Then you listen carefully, and you actually hear a systolic ejection murmur at the base in the axilla and in the back. So what's your diagnosis? You must know by now, because I think I mentioned the name before a few times. Anyone wants to guess?
Somebody wrote coarc.
Yeah, very good. Coarctation of the aorta. Okay, that's good. All right. So coarctation of the aorta, okay. And what do you do next? Well, it depends where you are situated and what you do, but usually you can get this type of test in your clinic, ECG and chest X-ray. So you may start with that. I don't know why my computer doesn't allow me to advance my slide. What's going on here? Okay, there you go. Okay, so you order a chest X-ray and EKG. The EKG is normal. Now I show you, this is a chest X-ray of someone with a somewhat severe coarctation, and you will see the rib notching here, and you can see, we call it the 3 sign here. But this is not often the case. Most of the time, you are going to have a normal heart and normal lungs, so it won't be very useful in coarctation. But if it has been going on for a long time, you may see those signs in X-ray. Of course, you are going to refer to a pediatric cardiology, and you will do an echocardiogram, and you see here is an ascending aorta, the transverse aorta, and then you can see the narrowing here in the proximal descending aorta. And then with the color Doppler, this is normally the way it should look, with no turbulence here and uniform blue, and then it gets, higher velocity in that area. So the echocardiogram will confirm the diagnosis. Now, the MRI is a very good test. I'm not saying that you are going to order that. It depends where you are and what approach is the most frequent. If people are doing surgery for repair, it may not be necessary. If it is going to be in the cath lab, it's good to know how many collaterals there are. So, in other cases, good, but it's not mandatory. But you can see here with the MRI the very narrow area of the coarct, and you can see the collaterals. And a cardiac catheterization, of course, will confirm the diagnosis of a narrowing, in that case, after the left subclavian. So you can see how close it is to the coarct, and sometimes the coarct actually goes in the proximal left subclavian artery, or sometimes the left subclavian artery comes below the coarct. So that's why it's important to take pulse in both arms. And then the treatment is usually either in the cath lab with a stent or surgery. Okay, so coarctation of the aorta is not a very frequent congenital heart disease, but it's something that as a PCP you need to know about, because you can be the one suspecting coarctation. So again, as we say, is abnormal pulses. We went over that already. Systolic hypertension, 1 or 2 arms, and brachial femoral delay. And so the message is you want to rule out coarctation of the aorta of any hypertensive pediatric patient. Okay. By the way, that case, when he saw the pediatric nephrologist, they actually took the blood pressure in all extremities, and that was documented. There was a gradient, but for some reason, the pediatric nephrologist didn't pay attention to that. Probably was in a hurry, and because the child was obese, and probably the provider was very busy, just went over it without realizing that really there was a coarctation. So very important to pay attention to those details. Okay, we have a few minutes here to go very quickly how to manage children presenting with symptoms. The message is that most children and adolescents presenting to your clinic with symptoms of chest pain, palpitation, and syncope will have a non-cardiac cause. Okay, for instance, only 4% of children presenting with chest pain have a cardiac problem. So that's the bottom line. It doesn't mean you don't have to exclude the cardiac conditions, but it is going to be rare. So these are basically basic recommendations. You go over growth and development if it is normal, if there is no symptoms, especially no symptoms with exercise, there is no family history of heart disease, the symptoms suggest a non-cardiac cause like chest pain after eating, syncope after a sudden change in position, palpitation during stress, You have a normal physical exam, and then you do the few screening tests, if necessary, that you can do in the clinic, ECG and chest X-ray, if needed. If all that is normal, you can definitely stop there, reassure the parents, and follow up in the clinic. On the other hand, if you have symptoms with exercise, you have a family history of early heart disease or sudden death, you have any suspicious cardiac findings on the physical examination or an abnormal ECG, then you are going to refer for more testing, okay? And so that's an inconvenience for the family, but that's necessary to do, all right? Any questions about this? All right. So in summary, most children who have a heart murmur have an innocent heart murmur. Okay, again, we talk about that, 80% of kids are going to have a murmur during their childhood. Doesn't mean they have it every time you see them. But, there are circumstances where if the kid is a little sick with a little fever or is becoming anemic, it's going to have a murmur for a while until that's over. But most children who have heart murmurs have no structural congenital heart defect because remember, only 1% of kids are born with congenital heart defect. So most of them are going to have an innocent heart murmur. And most children who have palpitations are going to have anxiety and a normal heart, but then you will need to try to get a history of the event, when are the palpitations occurring, try to assess if the patient is anxious. And then you may want to ask the patient to follow up at home, take the pulse, so you get an idea what the resting heart rate is, what it is during palpitations. If it is SVT, usually so fast you cannot even count it. But from anxiety, it's going to be like 140 or something. So it will be reassuring. You can have a patient come back. For chest pain, again, if it is only with exercise, it is a red flag. You're going to evaluate that. But if it is chest pain in other circumstances, there are multiple causes of chest pain. As I mentioned, studies have shown only 4% of chest pain in children are due to a cardiac problem. And again, the same with syncope. Okay, most of the time, syncope are going to be related to sudden vasovagal phenomenon, sudden change in position, and again, but you will go carefully about all the differential diagnosis. So before we, as primary care providers, come to that conclusion for our patients, we want to explore carefully to make sure we are not missing a cardiac diagnosis. Okay, I think that's the last one. Yeah. All right, and we have 5 minutes for questions, or otherwise a 5-minute break for you.
I'm just going to put some things in the chat while we wait for questions. So I just put a reminder in the chat about the CME survey and that it'll appear in a tab when you close out of this webinar. We really appreciate you taking a few minutes to complete this. Not only does this give you CME credit, but also helps us to plan the best session for you. We share the feedback anonymously with the speakers, and they greatly appreciate your thoughts.
Yeah.
And we'll still stay on. We have a few minutes if anybody has questions.
Yeah, the feedback is usually useful, so we can improve the next time we present. Okay.
And then I'll put something. We also do mentoring here at MAVEN Project. So it's a reminder that it's for all of our community providers at any point in your career, some topic ideas to reference: new to practice providers, challenging case review, preventing burnout, building teams. We also offer specific mentoring like EKG or CGM. So I'll put that in the chat as well, but we still have a couple minutes. If anybody has any questions, you can put it in the Q&A or put it in the chat. And I do see one in the Q&A. Would you recommend that all young children with hypertension get an echocardiogram to evaluate for left ventricular hypertrophy?
Well, you go on a case-by-case basis. If you have long-lasting hypertension, it's not responding to medications, for sure you are going to want to assess where it stands, make sure there is no, as you say, LVH or any other things going on. So I wouldn't say routinely you do that. I mean, most frequent cause of hypertension is going to be a renal cause, and you see if that can be, if it is a renovascular cause, that is going to be taken care of surgically, but otherwise, hopefully it would be taken care of by medication. And if it is controlled, I wouldn't say it's necessary. You can follow the EKG. Again, the echocardiogram, it depends again where you are practicing. I mean, if you practice and next door is a pediatric cardiology, why not? I mean, it's not a bad idea. But for lots of people, it is quite an inconvenience. They have to wait a long time for the appointment. Then they have to travel a long distance and all that. So I would not do it routinely. But there are times where it's not a bad idea. Yeah. So where is Mariposa? Where is Mariposa Clinic? Is that in Arizona? No.
I believe it is Arizona, but yes, I don't know how to say the town, but
Oh,
I
yeah,
can.
Nogales,
Mhm.
Arizona. Oh, wow. Okay. So how far are you from a tertiary center with pediatric cardiologists at Phoenix and Tucson, I guess? How easy it is for the patients to go to a pediatric cardiologist in Nogales? Okay, yeah. All right.
Okay, so that is wrapping us up. They said 1 hour south of Tucson.
1 hour south of Tucson. Oh, wow, that must be nice. Okay. All right.
Okay.
Wonderful.
Thank you so much, Dr. Rogé. I love that. Thank
Anytime.
you for everybody attending. And I hope everyone
Okay.
has a great rest of your day.
Okay. Thank you. Okay. Bye-bye.
Bye.